When we hear the term heart failure, most of us immediately picture one thing: a weak, worn-out pump that just can't squeeze hard enough anymore. But in modern cardiology, that's really only half the story, and honestly, it might not even be the most dangerous half. So in this explainer, we're going to deconstruct this whole clinical syndrome. We're going to move way beyond that simple model of pump failure and explore the two very different paths that really define the front lines of cardiac medicine today.
So let's just dive right in and challenge that core assumption. Is heart failure really just a problem of a weak pump? Well, the short answer is a hard no. The reality is so much more complex, and it has essentially split the world of cardiology into two completely distinct battlegrounds.
So here's our game plan. First, we're going to redefine heart failure with its proper clinical definition. Then, we'll introduce the two major subtypes. We'll take a deep dive into the classic form, HFrEF, and the revolutionary treatments we have for it, before we try to tackle the really dangerous and unsolved puzzle of HFpF.
Okay, to really get started, we have to shift our thinking. We have to move past this idea of heart failure as a single disease. It's not. It's actually a clinical syndrome, which is really just a collection of signs and symptoms that act as the final common destination for a whole host of underlying heart problems.
And here we have the official definition from the American College of Cardiology and the American Heart Association. Now, pay very close attention to that critical phrase. The problem is the ventricle's ability to pump out blood or fill with blood. That little word, or, isn't just a minor detail. It's everything. It's the fundamental fork in the road in how we understand heart failure today. The inability to pump, that relates to something called inotropy, which is the contractility or the squeeze of the heart muscle. The inability to fill, that's about lusotropy, the muscle's ability to actively relax. So that fundamental split between a problem with the squeeze and a problem with relaxing leads us directly to the two major types of heart failure that dominate all of cardiology right now: HFrEF, which is heart failure with reduced ejection fraction, and HFpEF, heart failure with preserved ejection fraction.
Okay, so let's break this down. On the left, we've got HFrEF. This is your classic weak pump. It's a systolic failure, a failure of contraction. The ejection fraction, which is just the percentage of blood the heart pumps out with each beat, is low, 40% or less. Now, this is the type of heart failure where we've made absolutely incredible progress with treatments. But on the right, we have HFpEF, the stiff heart. This is a diastolic failure, a failure of relaxation. The pump squeezes just fine. The ejection fraction is normal, 50% or more, but it can't relax properly to fill up with blood. And here's the truly terrifying part. We have almost no proven evidence-based treatments for it.
Now, before we go any deeper, it's really useful to know how the disease is classified over time. The ACC/AHA staging system looks at the structural progression over a person's lifetime. So stage A is someone who just has risk factors like high blood pressure. By stage B, there's actual evidence of structural heart disease like a thickened heart muscle, but the person feels totally fine, no symptoms. Stage C is when the symptoms finally show up, and stage D, well, that's advanced end-stage disease. So if the stages are about the long-term progression, the New York Heart Association, or NYHA, classes are more like a snapshot of how a person is feeling at any given moment. It's all about symptom severity. It goes from class I, where you have no limitations at all the way to class 4, where you have symptoms even when you're just sitting at rest. It gives doctors a quick way to gauge a patient's functional capacity right now.
All right, time for our first deep dive. When we talk about HFrEF, the central problem, the real tragedy, isn't just the initial damage to the heart, it's the body's own catastrophic attempt to fix the problem.
So think about it like this. The heart's output drops, and the body's alarm bells go off. It panics. It activates the sympathetic nervous system and the renin-angiotensin-aldosterone system, or RAAS. This makes the heart beat faster and harder, it clamps down on blood vessels, and it makes the body hold on to salt and water. Now, in the short term, this keeps your blood pressure up. But long term, it's like whipping a tired horse. It puts this incredible strain on an already struggling heart, and it kicks off this vicious cycle of damage we call destructive cardiac remodeling, where the heart muscle literally changes its shape and size for the worse. And all that internal chaos shows up as a pretty clear triad of symptoms. First, you get forward failure. That's from low cardiac output, causing things like fatigue and cold hands and feet. Then you get backward failure. That's from blood backing up into the lungs because of high pressures, and it causes severe shortness of breath, what doctors call dyspnea. And eventually, all that pressure overloads the right side of the heart, leading to right-sided failure. And that's when you see fluid backing up in the whole body,
causing things like edema or swelling in the legs and ascites, fluid in the belly.
So here's the breakthrough. Once we finally understood that the body's own solution was actually the core of the problem, the therapeutic strategy became brilliantly clear. We had to block these overactive systems. And this led to what is, without a doubt, one of the great success stories in modern medicine. We have what doctors call the Fantastic Four. These 4 classes of drugs are the foundation of HFrEF therapy. You have beta blockers to block the sympathetic system. You have ARNIs and MRAs to block that RAS system and reduce all that harmful vasoconstriction and fluid retention. And now we have SGL2 inhibitors, which provide a whole host of other benefits. Together, this cocktail of neurohormonal blockade has completely revolutionized HFrEF care, and it's been proven time and time again to save lives.
But just as we were starting to master HFrEF, the sheer scale of the other crisis became terrifyingly clear. And so now we turn to HFpF, the next great unsolved challenge in all of cardiology.
See, unlike HFEF, HFpEF is really understood now as a systemic disease. It's driven by a whole cluster of other common conditions, hypertension, obesity, diabetes, that together create this state of chronic, low-grade inflammation throughout the body. This inflammation seems to target the tiny blood vessels in the heart, leading to fibrosis and a stiffening of the heart muscle cells themselves. It impairs that crucial untwisting motion the heart needs to do to relax properly.
And the clinical result of us not having a solution for this is, well, it's devastating. This chart just lays it out. The number of guideline-directed medical therapies that have been proven to improve mortality in HFpEF, 0. And because of that, the 5-year survival rate is stuck at around 40%. To put that in perspective, that's a prognosis comparable to many advanced cancers.
So what makes it so deadly? It's a chain reaction. That stiff ventricle can't relax to let blood in, so the pressure inside the chamber at the end of its filling phase, what we call the left ventricular end diastolic pressure, or LVDP, it just skyrockets. That insane pressure gets transmitted backward into the lungs, causing terrible shortness of breath. It also stretches the atria, the top chambers of the heart, making atrial fibrillation, or AFib, an incredibly common problem. And getting AFib when you have HFpEF is a disaster, because these stiff hearts are desperately dependent on that final kick from the atria to get enough blood in. Losing that kick can cause a complete collapse. This quote really just captures the whole paradigm shift perfectly. For decades, we were completely obsessed with ejection fraction as the be-all and end-all of heart health. We know now that a normal EF can hide a truly deadly disease. It is, absolutely, time to move on.
So we have to end with this really critical question. Right now, HFpEF accounts for about half of all heart failure cases, and that number is actually rising. We've got a therapeutic toolbox for this huge group of patients that is, for all intents and purposes, empty. So the central challenge for cardiology is clear. We have to unravel the complex story of this systemic disease. Developing therapies that can actually treat the stiff heart isn't just some academic exercise. The lives of millions and millions of patients truly depend on it.